So I'll talk about management of patients with relapsed mantle cell lymphoma. Really, when we think about management of these patients, we think both about the lymphoma-related factors, in other words, the presentation. This is their CNS involvement. We look a little bit at biology and prior therapies, and then also I think we need to consider patient-related factors. Goals of care are probably key to all of that. Comorbid conditions and fitness are also important. So with respect to lymphoma-related factors, I think the presentation is fairly self-evident. The rate of progression is reflected both in the disease biology with Ki67, but also clinically, I think we can get an idea of how somebody is progressing, how rapidly they're proliferating. Unfortunately, I don't think that proliferation by itself is necessarily an indicator of how we need to treat somebody. We know that it's a poor prognostic marker, but I'm not sure that it's a predictor of a response to one therapy over another. This is a study that looked at Ki67 as relapse compared to remission, or diagnosis compared to relapse. And you can see that in general, Ki67 tends to increase in patients when in their relapse sample. Ki67 was predictive of survival both at original diagnosis and at relapse. So it maintains its prognostic significance, but again, I'm not sure that we know necessarily what to do with that information at this time. So what about treatment options? I thought I would focus really on a few treatment options that we have access to in the United States and Europe, and why they might be reasonable. So there's in fact, very little data. These slides are a little bit funky. There's very little data with single-agent Bendamustine in mantle cell lymphoma. This was a phase 2 study looking at Bendamustine plus Rituximab in patients with indolent lymphoma and mantle cell lymphoma. There were a very small number of people with mantle cell lymphoma, only 16 out of the 63. Most of them were not very heavily pre-treated, and none of them had prior Rituximab. With that, the combination of Bendamustine and Rituximab had a median progression-free survival of only 18 months. So in short, Bendamustine, Rituximab, not a lot of data at this point in time, although it's probably one of the most commonly used second-line regimens for mantle cell lymphoma right now, and certainly not a lot of data using Bendamustine, Rituximab after the very heavily pretreated patients that we're often seeing with mantle cell lymphoma. How about just Rituximab by itself? Is there a role for single-agent Rituximab? This was an older study looking at just single-agent Rituximab, either in patients with previously treated mantle cell lymphoma as a single 4 weekly doses, or 4 weekly doses followed by an additional 4 doses during the course of the year. And you can see that there really wasn't an improvement in progression-free survival with addition of Rituximab, additional doses of Rituximab. And it's a little bit hard to interpret this, particularly in the context of the recent European Mantle Cell Lymphoma Network study that showed there was a benefit to maintenance therapy. But in my mind, this suggests to me that in somebody that still has considerable evidence of lymphoma, use of single-agent Rituximab probably doesn't add a lot. What about some of the newer anti-CD20 antibodies? Ibrutinib has been studied in mantle cell lymphoma in a very small number of patients. And in this study, only 1 out of 7 patients with Rituximab refractory mantle cell lymphoma had responded. So it's available off-label in the United States, but as a single agent, I'm not sure that it is the right choice for patients with relapsed mantle cell lymphoma. Temsirolimus, Dr. Witzig, really was involved very much in the development of this early on and showed already some of the data. This was from the international phase 3 trial. And you can see that the PFS data is a little bit worse than some of the original phase 2 data, but when you look at the patient population that it was on, it's a very heavily pretreated patient population. They had all received prior Rituximab, they had all received an alkylator, and all received an anthracycline. And a third of them had received a prior autologous stem cell transplant. Nonetheless, the PFS is not really overwhelming. It clearly has some activity. I think we know why it works now after seeing Dr. Witzig's lecture, but we also know why it probably doesn't work as well as it might. Dr. Witzig also showed the addition of Rituximab to Temsirolimus, and I just wanted to note in the slides and in the book as well that in the Rituximab refractory patient population, the PFS was only about 6 months. So in my mind, although Temsirolimus clearly has some activity, I'm not entirely convinced that the addition of Rituximab to Temsirolimus in a Rituximab refractory patient population necessarily adds much. Bortezomib. So this is the pinnacle trial that actually got approval for Bortezomib in mantle cell lymphoma, or an accelerated approval for mantle cell lymphoma. And again, this patient population was fairly heavily pretreated. Almost all of them had received essentially probably R-CHOP, and a third of them a prior high-intensity therapy, which may have been hyper-CVAD or a hyper-CVAD-like regimen or an autologous stem cell transplant. And what I want to highlight here is that whether patients had received prior high-intensity therapy or not, they had a similar overall response rate of a 20 to 30% range and a similar progression-free survival, suggesting that Bortezomib, although it's not overwhelming in terms of its activity, the mechanisms of resistance to Bortezomib may be different than the mechanisms of resistance to chemotherapy, which may be why, with respect to addition to chemotherapy, it definitely adds something, as we saw in the frontline study just presented at ASCO this summer. How about Lenalidomide? So Lenalidomide, this was the paper that Dr. Witzig, in fact, I can't remember if he showed this one or not. Dr. Witzig was involved heavily in the development of Lenalidomide as well. Not surprising that he's here today to talk to us about mantle cell lymphoma. So this was in the mantle cell lymphoma patient population in a small phase 2 study, 42% response rate. Again, a fair number of those patients had had significant prior therapy. But when we looked at the rates of progression-free survival in the eMERGE study that he just showed us recently, in which all patients had received prior Bortezomib, the overall response rate dropped a little bit down to closer to 20% or 20 to 30% with a shorter PFS. So Lenalidomide clearly has activity in a less heavily treated patient population. The more heavily pretreated the patient population, less activity. Interestingly, though, as he mentioned, there are patients who have remarkably durable remission duration. And this, to me, I think, interestingly, the cytokine data goes along with it. Dr. Ruan will be discussing frontline treatment of mantle cell lymphoma later on this afternoon. And I think it certainly will raise questions about when lenalidomide should be used for mantle cell lymphoma. This was data from the MD Anderson phase 1/2 trial presented by Michael Wang, who showed that the addition of Rituximab to lenalidomide may add something more than we might have expected. This is, I think, consistent with data from follicular lymphoma. There was the CALGB 50403 study that Dr. Leonard has presented that shows that addition of Rituximab to lenalidomide is superior to lenalidomide itself in follicular lymphoma. And I think there's a suggestion that that may also be the case in mantle cell lymphoma. So here you see that even in patients with Rituximab refractory mantle cell lymphoma, still almost half of them responded. How about Ibrutinib? So Ibrutinib is the latest and greatest of all of these. These are a small subgroup analysis. I cut and pasted it to highlight prior therapies. So you can see that essentially regardless of the number of prior regimens, whether the patients were refractory to their prior therapy or not, whether they had received prior high-intensity therapy, prior lenalidomide, and not on here actually was prior Bortezomib, the response rates were pretty similar, always in the 60 to 70% range. So finally, I'll talk about stem cell transplant, so autologous stem cell transplantation. This is data from the CIBMTR registry looking at when autologous stem cell transplantation or allogeneic stem cell transplantation is done and how patients do with it. And it's data that's been presented in different series, both MD Anderson and I think Nebraska also had a series suggesting that the outcome if the transplant is not done after first remission is not as good. So you'll get a shorter PFS if the transplant is done in second CR or later. Interestingly, when they look at overall survival from the time of diagnosis, there's no real change, which to me suggests that the relative benefit of the transplant is essentially fixed, and whether it's done early or late, I'm not sure that there's a huge difference in my mind. However, if you relapse after autologous stem cell transplantation, survival outcomes can be pretty bad. So relapse within 12 months after autologous stem cell transplantation for mantle cell lymphoma has essentially a very dismal survival. And that's true actually in multiple series. And it's essentially true in my mind whether or not you get an allogeneic stem cell transplant. It's clear that allogeneic stem cell transplantation is probably the only real way to salvage patients who relapse shortly after autologous stem cell transplantation. However, even those patients that do get an allogeneic stem cell transplantation following a very brief remission after autologous stem cell transplantation do pretty poorly. So these are my conclusions. Either Bendamustine or Ibrutinib should be considered for second-line management of patients with relapsed mantle cell lymphoma. I think if they've received one, then they should probably receive the other. I think, in my mind, that the addition of Rituximab to Bendamustine is reasonable. There's a how to treat mantle cell lymphoma in blood, and there the authors argue, I think fairly reasonably, that they don't add Rituximab if patients have already received it in the front line. My bias is to continue adding it. I think it's worthwhile considering adding Bortezomib to Bendamustine in the second line setting. Granted, there isn't a lot of data for it. There are 2 trials that have combined Bortezomib with Bendamustine. One of those included a very small number of patients with mantle cell lymphoma, but extrapolating from several other series that demonstrate Bortezomib may add something to chemotherapy, I think it's worthwhile considering. I think that retreatment with single-agent anti-CD20 antibodies are unlikely to be beneficial. Single-agent Temsirolimus has modest activity in patients that have received a lot of prior therapies, and it's unclear to me if Rituximab improves outcomes, particularly in the Rituximab refractory patient setting. Bortezomib, also modest activity in this patient setting, but I think it seems to add significant improvements to immunochemotherapy. I think that it sensitizes patients to chemotherapy. Lenalidomide, modest activity. I do believe that the addition of Rituximab to Lenalidomide may capitalize on some potential synergy there. So I would consider that. I didn't add Ibrutinib there. One of the big questions is how to manage patients that have relapsed on Ibrutinib. Anecdotally, there's suggestion that these patients don't do well, and so far there's no data on how to deal with a patient that's relapsed on Ibrutinib. Patients that have not received a prior autologous stem cell transplantation may still receive a durable remission from a transplant if they're able to achieve a complete response prior to that transplant. So if for whatever reason a young patient decided against a frontline transplant, I think it's still reasonable to consider a transplant in second CR as long as they get a good CR. Patients that relapse within 12 months of autologous transplant have a very poor prognosis, and a small number might achieve a durable remission from an allogeneic stem cell transplant. The optimal timing, I think, of allogeneic stem cell transplantation remains very much unclear. So that's it. I think we will